Good afternoon and welcome. I want to thank the Kaiser Family Foundation for hosting us today and Jen Cates for being our moderator. I'm Chris Collins. I'm with Friends of the Global Fight here in DC. I also want to thank our co-sponsors for today, Malaria No More and Nothing But Nets. And a very big special thank you to our wonderful speakers today, Ambassador Deborah Birx, Dr. Nolutshungu, Kate Roberts, and Rear Admiral Ziemer. Thank you very much for being with us today. Well, we just had a successful Global Fund replenishment last month in Montreal and got very close to the goal for the Global Fund. Several countries made big increases in what they pledged. 9 African countries are now investing directly in the Global Fund. And let me emphasize, this was the launch of replenishment. More funds are expected to come in, and they'll be needed and put to good use. And again, U.S. leadership was absolutely critical in getting so close to the goal. And we want to thank the Obama administration for their continued support for the Global Fund. The success of replenishment this year sends a very important message, particularly coming off the Kaiser family study that we got this summer, showing actually a decline in donor investment in global AIDS this year. So hopefully a successful replenishment is a sign that we can turn that investment around, just like we did in 2011, where there had been a dip in global AIDS investment and it went back up. So today we want to look forward. And a lot of things are changing right in front of us. We will have a new administration coming in, a new Congress, and it's true on the bigger picture that the health financing picture overall is transforming in the world. Now, as everybody here knows, we have a great track record in delivering results in global health investments. Death from malaria, TB, and HIV are nearly cut in half since 2000. Incidence is down in all 3 of those diseases. You may have seen a study that just came out today in Kaiser Daily Reports showing that in the last 35 years, the world has added a decade of life expectancy just in that time, which is really pretty amazing. And we can also celebrate that global health in our own country remains a bipartisan issue. And all that success means that we're actually talking about global health and the 3 biggest infectious disease killers in a different way than we used to. It's no longer just about alleviating suffering and bringing down mortality, though of course it is about that. Now we're talking about how do we actually end these epidemics. When she made the U.S. commitment at Montreal at Global Fund replenishment last month, Deputy Secretary of State Heather Higginbottom said, "We're not only committed to fighting these epidemics, we are committed to ending them by 2030. And in fact, the Global Fund strategic plan is titled Investing to End Epidemics. Now, this focus on making these epidemics history is a very, very good thing. But let's be clear, that new focus, that bigger focus, has implications for policy and programming and for financing. Ending it means a bigger global health pie, not just a bigger slice of the pie for one program or the other. And let's be clear about our situation. Based on the investment case from the Global Fund that came out last December, the $13 billion goal for Global Fund replenishment is great, but it is consistent with only 80% funding that we need to ultimately end these epidemics by 2030. And that's assuming very big increases in domestic investment and sustained donor engagement. And for all the progress that we've made to date, which is huge, it's also true that the path forward in each of these 3 major infectious diseases has plenty of challenges to it. It's possible to end them, but now is the time to recommit, not to celebrate. And also, we really can't afford to delay this conversation about investment and filling that gap in fully funding the responses to AIDS, malaria, and TB. For example, in HIV, UNAIDS has observed that we need to be front-loading investments now to drive down incidence and mortality in the near term so we can have any hope of reaching that 2030 goal. So today, let's talk about the things we need to be grappling with in the next 6 months and year as a new administration comes in, a new Congress, and we look forward. How do we remake the case to decision makers and to the general public about the need to invest and increase investment in global health? how are we going to transform funding and ensure that marginalized populations are not left behind? What does the universal health coverage movement mean for global health financing overall? And ultimately, how are we going to bring together donor commitment, domestic funding, innovative finance, and the private sector to meet that financing goal that we must meet to end these epidemics? We all know that we're fond of saying that we're at the tipping point in HIV and malaria and TB. We're on the right side of the tipping point. And as Mark Dybald, the executive director of the Global Fund, said in Montreal last month, the thing about tipping points is that you can go either way. And we have to be particularly cautious about this with infectious diseases, which can come back worse, particularly when you think about drug resistance. So for today, the question is, how do we finance tipping the right way on the three biggest infectious disease killers and on global health in general? And with that, I'd like to introduce our moderator, Dr. Jen Cates, Vice President and Director of Global Health and HIV Policy at Kaiser Family Foundation. Jen.
Thank you, Chris, and hi, everyone. I apologize in advance for my voice, recovering from whatever's going around, but if I start to have a coughing fit, let's just say I'm in good company. So I also want to thank Friends and all the sponsors for asking me to be part of this and for having the foresight to do this discussion now. When we first started talking about it, it was pre-replenishment, and we actually didn't know what the outcome was going to be, so we didn't know what we were going to be saying today. And as Chris mentioned, the future stability, let alone growth of financing for these three diseases is not a certainty. And there's troubling signs that Chris alluded to around donor funding for HIV. There's some challenges with the global economy. People have probably been reading about this. The US dollar appreciating at very high rates, which has an impact on other donors and other factors that are in play. But replenishment did go well. The $13 billion goal was just about reached. And despite the questions we might all have about the future leadership in this country, but also not just this country, in many other places, we have a strong legacy of bipartisanship. We know from our polling that we do pretty regularly, the US public, at least, is very supportive of global health investments, of the Global Fund. In fact, our last poll just a few months ago found that 77% of the public says the US should give money through the Global Fund and other international organizations as a way to address health challenges. So that's the landscape that we have. Enough from me. I'm going to briefly tell you who we have here, though I think everyone knows who we have. But then I'll turn to them and let them share with you and us what they think are some of the challenges, ideas, ways forward, and then we'll come to your questions as well. So first, we have Ambassador Debbie Birx, who's the U.S. Global AIDS Coordinator and U.S. Special Representative for Global Health Diplomacy. She has been in that position since 2014. She really needs no introduction.
Thank you. So don't.
But I have
to. Let's just move down the line.
Yeah, I really quickly have to say that we know that she's been leading efforts to combat HIV since the epidemic began at DOD, Walter Reed, CDC, and now at PEPFAR. But really brings what I like to say about you is bring unparalleled clinical and technical expertise coupled with incredible passion, strategic vision, and diplomacy that's really making a difference. Thank you. Next, we have Rear Admiral Tim Ziemer, who is the U.S. Global Malaria Coordinator and leads the President's Malaria Initiative, which he's been doing since almost its inception. And before that, had a long career in the Navy. Has also been leading international organizations, including World Relief. Also, thank you for everything that the PMI has done. We also have Dr. Nomonde Nolutshungu, who's the health attaché at the South African Embassy here in Washington, where she represents South Africa with the U.S. government, with NGOs and all other partners here, and has been working in HIV and health in South Africa for many, many years. We also have Kate Roberts, who's with the Maverick Collective, which we're excited to hear about, also a senior VP at PSI. She has designed and led several highly successful public health initiatives, particularly focused on youth, and she'll tell us more about that. And then last but not least, Chris Collins, who's the newly installed executive director at Friends of the Global Fight, but everyone knows Chris from his long years of advocacy. Prior to Friends, was at UNAIDS for 2 years. Prior to that, was here at AMFAR in DC, made a huge difference in domestic and global HIV advocacy, has done many, many things over the years, including starting his career with Congresswoman Pelosi, working on HIV many, many years ago, We missed you, Chris. Welcome back. Thank you for being here. All right, so let's go to our panel. I'm going to start with Ambassador Birx. Chris said I have two questions that kind of go together, but Chris said that we're going to want to hear about making the case now. And what's the case for investment? If we have a new changing of the guard, U.S. leadership, but generally a global discussion where I think people are looking for that case. What is the case to be made? How can they justify it? So what would you say to that? And then related to that, this issue of mobilizing domestic resources, which is making the case at the country level.
Great. Okay. Well, that's a deep question, and I just got off a red-eye flight, so we're gonna give our best shot at this. So, to my mind, making the case has two parts. One, to be very clear about where we have been successful and why, and we're really using data to really understand that. We've been remarkably successful in the areas that built on the existing health system that existed in resource-limited settings. And that was building on the maternal-child health relationship of supporting children under 5 and supporting pregnant women. So when you look at our dramatic success, it's been in getting women tested of childbearing age and on ART, and basically decreasing new pediatric infections by 70%. But what that then unearthed and uncovered was this ongoing and unrelenting epidemic that has now shifted very much so from an epidemic that was in over 30s to very much an epidemic in under 30s. And the demographics have dramatically changed, particularly in sub-Saharan Africa, with now 20% more, 100% more 15 to 24-year-olds. So twice as many 15 to 24-year-olds who don't know their HIV status, who don't believe they're at risk for HIV, and are that primary source of new transmission. So I think it's really critical that when we talk about issues, we talk about where we were successful and then why, and then how we're going to bring that same level of success in an area where we have not been particularly successful, and why we need new ways of thinking about it and new ways of trying things. So that's part of what DREAMS is, and it's great to see Johnson & Johnson here, and I know we're going to talk about the role of the private sector. To me, it always has been the creative and innovative insights that they bring along with the money. People always talk about the money that the private sector brings. That's great, but we really want to broaden that tent of thinking about an issue that we have not been specifically successful in, and they have been. And that's marketing to under 30s. So we're really trying to really look at every place and be honest with ourselves. This is where we've done a great job. This is where we've not done such a great job. What are we going to do to improve that? And that's what DREAMS is about. That's why it's very restricted in very high prevalent districts, because no one's tried to do what DREAMS has tried to do. And we want to really figure it out and then take it to scale. And I think that partnership between the advocacy groups, the women's groups, the host government, and all of our implementing partners, and that continuous assessment and evaluation of our data is going to get us to that new place. But I think that's what we need to really tell people and then show the counterfactuals. Because what I just described to you is a tipping point in the wrong direction. When you have twice as many of something and you haven't impacted the infection rates there, then you end up with twice the burden of disease, which no one can afford. So part of it is we have not made a business case that everybody in ministries of finance can understand why a health investment and why a health investment right now is important in a time when they don't see anyone dying of HIV. I mean, the World Bank is meeting, and I bet if you went over and asked ministers of finance what HIV is in their country, they would say, what HIV? Because their idea of HIV was AIDS and people dying. So it's on us to really change the dialogue and to use clear data to show where we're headed, where we should be heading, how we get there in a very clear way, using data in an iterative, continuous process. And that's my challenge again to all of you, because you know every time I get with your brains, I really want to challenge you again. Help us visualize data better. Help us do that, because you know we've said you can't manage what you don't measure. Now we're measuring it, but I can tell you can't manage it unless you can understand it and use it. And we talk about that like that's something that just happens. An Excel spreadsheet doesn't make it happen. A graph does not make it happen. Something that moves and shows where we're headed and the impact that's going to have and how we could change that and where we could be and whether we're on track, not in a weekly basis, but maybe a monthly basis, and really helping us capture people's imagination of seeing themselves in that data and part of the solutions. I think it's an exciting time, because I think people have learned how to, I don't know how much, when you're on Gmail, not that I use my Gmail account, but I use my Gmail account when I write to my daughters. My daughters only. But when I'm in my Gmail account, it's sending me stuff. My daughter just got married. I get Pinterest marriage things all the time just because I bought marriage stuff. So someone out there knows what I'm doing in that giant cloud. We should be able to do that same thing with global health, where we know down to the level of the community who's there, what they need, and how we're going to get it there in an effective and efficient way. I think it's a terrific time to be in global health.
That's a great way to start us off. So given that, I'm going to follow up one question to you on the domestic resources. And I know it's been something that PEPFAR has been trying to do at Global Fund, PMI. How do you make the case and work with governments to mobilize their own resources?
I think there's two pieces of that. One is, we just talked about how the health system was very much gauged around maternal child health. So when you talk about adolescent health, when you talk about young people, then it's not just about what is the government doing, but what this community is doing. Because they have to be the partnership in that wellness. And we didn't get it so great here in the United States, but we have a chance to get it great in every other place in the world that we're working in, to really work in that partnership between communities and governments. Because if we work on that wellness piece, then you're talking about visits that are yearly rather than acute care visits that are constant. And it really changes the whole affordability. And I think universal health care coverage, to me it's exciting because of that word universal. Because now it means gay, straight, rich, poor, rural, urban, you have access. And I think that also gives us another place to talk about the rights to health and the ability to really deliver on that. So I think what we've been working with governments on, and I think South Africa is such an extraordinary example, when we talked about dreams, at the beginning we were a little confrontational about that discussion.
Yeah.
You know, we were like, what? You know, we're gonna go there and we're gonna go there together. And they were like, no, you're making us go there. That's not going there together. And very clearly pushed back and said, we need to go and understand this at our pace and understand the risk. And when they looked at all of the data, they were like, yeah, dreams is great, but we need something more than dreams. And the government, after looking at their analysis, stepped up and took dreams everywhere in a really comprehensive, countrywide, let's look at what it takes to protect young women from HIV and really work at what the issues are and what the data teaches us. It's really been extraordinary. They were right all along. It took an extra 2 to 3 months, but 2 to 3 months is not, to me 2 to 3 months is a long time, but in the big picture of where we got to, instead of a $70 million investment, it's a $300 million investment with Global Fund, host country investment. And that's when you take that extra time and you listen and you wait and you learn together, you can be at a very different place. So that's the kind of model that I think is possible when we make the case built on data.
So let's go to South Africa and Dr. Nolutshungu about South Africa's response and role. South Africa pledged $5 million to the Global Fund.
Yes, that's
and as we just heard, this is just one example of the investments the country has made in its own HIV response, TB response. How does those lessons and that role get shared with other African countries? There's more that came forward at the pledging conference,
Yes.
which was really, how you said it was 9, Chris? I think 9 countries.
9
so,
countries.
But there seems to be more political will. What's the dialogue that needs to happen? What can be done?
Well, perhaps I should frame my response into demonstrating or showing people where the epidemic is in the country. Home to the largest number of HIV positive people in the whole world, the 3rd largest TB epidemic in the world, we have no choice but to be friends of Global Fund in terms of a response to those epidemics. Ambassador Birx was referring to data and granular data. You know, initially when we started, all we knew about the HIV epidemic was about prevalence. We've since now gotten to understand better issues relating to incidence, the rates of new infections. We know about morbidity, we know about mortality, and now to this point where we can say, not only in this community, but in a particular village in this community, in a particular age group amongst young people, which then directs the resources in terms of policies and programs. That is the point where we got to better understanding using data, and therefore then targeting in a more informed, as I say, granular way, what to do with the resources that we have in terms of policies and so on. What that has also done is to inform what we now have on the table discussing with politicians, with the private sector, an investment case. With all of the scenarios explained in that investment case, it is sort of a detailed crystal balling that's informed, telling you if you do this and not do that, what then are the outcomes that you should expect. It tends to give information to policymakers and decision makers in terms of where to direct resources. We do have now that level data. We do have an investment case. In terms of what the country has done to respond, since 2 decades ago, we started to respond to HIV and AIDS. We now have a national strategic plan that has been actually discussed and agreed upon by all role players in the country. It's not only based on HIV and AIDS, it's only in the umbrella of the whole development trajectory of the country in the form of the National Development Plan, which is a long-term plan, also put together in a democratic kind of way, involving everyone to decide what it is that should be done in that country. Within that, then, you would find the targets and the objectives and goals that relate not only to HIV, but also to TB. It has been clear to us recently that if we don't deal with the problem of TB in the country, doesn't matter how much we do in HIV, because most of the people that have HIV in the country die from TB. So we also have to do something about the problem of TB in the country. When we looked at the problem with TB, we also saw that there's a problem with development of drug-resistant TB. So innovative and biomedical interventions to ensure that we find early those people who have drug-resistant TB have been part of the solution of the problem of HIV and TB in the country. Within that, we have what we call the medium-term expenditure framework, a rolling kind of plan with policies that are with resources committed to deal with the challenges of the country. So in a 5-year kind of term plan, there are commitments to financial commitments to make sure that we address the challenges that relate to HIV and TB. So within the rolling plan of the medium-term expenditure framework, there is targeted money put aside to deal with the problem of HIV and AIDS in the country. What we have seen, if you look at how much we have expended towards solving that problem, there has been about 5-fold increase in the commitment and expenditure to deal with HIV, AIDS, and TB. But also in the last 5 years, 27% more increase in resources committed to the problem of HIV in the country. So I'm afraid to say, even with that, that is not enough. We have to continue to contribute to Global Fund, to make sure that the Global Fund functions, to make sure that the bilateral collaborations with PEPFAR and others work to augment what the country has done. It is the country where you need to be if you're looking at the global kind of extent of the problem of HIV and AIDS globally, basically.
Thanks. I want to actually pick up on something you said on the Global Fund
Sure.
and go to Admiral Ziemer and talking about the relationship between the Global Fund and bilateral programs and think about it from PMI's perspective, just what that, we hear about it all the time. What does that mean and how has it been leveraged to increase value? Where are the challenges still? And then I have a follow-up question for you on
Great,
PMI.
thanks, Jen. Let me just step back for a second. I caught your cold, so I have a little bit of a hoarseness. I think that's the Lord's way of telling me to transmit less and receive more. Okay, but I'm going to do a little transmitting here. First of all, Chris, your summary was great because it really did position why we're having this event now and why it's so important. Transition, change of leadership, is kind of a normative thing. But how we position ourselves as partners looking into the future is critical. So I think coming off the Global Fund replenishment, everyone in this room, and as I look around the room, I see everyone in here, a lot of friends and partners who helped facilitate and actually enable this magnificent almost $13 billion. So we all have an opportunity to celebrate and then get on with work, okay? Because much of this discussion isn't a discussion of potential and ideas. The real challenge, as Ambassador Birx mentioned, is how do we take the ideas and the data and link it into the reality on the ground? And so from a PMI perspective, and I'll put my PMI hat on now, the relationship with the Global Fund as a multilateral or a major funding partner and a U.S. government bilateral partner is a great example of effective partnership, okay? When PMI was launched, one of the criteria to select a focus country was to make sure the U.S. government was not the only major funder, be it DFID, UNICEF, the World Bank, or the Global Fund. In fact, after the first year, only 3 of our 15 focus countries were beneficiaries of Global Fund grants. The Harmonization Working Group met under the auspices of the Rollback Malaria Partnership and determined to do something about that. And in a year and a half, 9 of the 15 U.S. government focus countries were beneficiaries of the Global Fund grants. And today, all 19 of our focus countries are beneficiaries, partly because of a planned, deliberate, intentional focus to look at ways to help the countries prepare their concept notes, go after the grants, get them approved, and then put them to work. Now, PMI, and we all know in this room that the Global Fund doesn't have technical assistance presence on the ground. They depend on partners and the governments. PMI, very much like PEPFAR, although at a much reduced level, has 2 resident advisors, malaria experts with every country program, plus a number of Foreign Service nationals that are malaria experts, and a number of supporting members of the team, all focused on doing malaria to support the country national plan. Part of that agenda is to work closely with the Global Fund. And I tell Mark Geibel that not only is it a privilege to work with the Global Fund, but we make him look good, okay? Now I say that with the tongue in cheek because the resident advisors, the experts, work closely with the Global Fund at the headquarters level, at the regional level, and at the country level. And it is that country presence, working with the country partners and the Global Fund folks, that actually help leverage the funding, look at the country gaps. Case in point, if the Global Fund pays for bed nets for a mass campaign, we may step up to the plate and pay for distribution, hang up, keep up, and check up, okay? If there are commodities to be purchased, the Global Fund may buy the commodities, we pay for the training, logistics. Whatever the country needs, wherever the gaps are, our country support teams actually facilitate that. So that teamwork between the Global Fund and the U.S. government bilateral program was intentional, It's effective, it's working, and it's getting better. And it's a model on how to do effective partnerships. I'll just stop there.
Great. You actually answered my second question, so I can just go down and give you a break with
Good.
your voice. So I'm going to go to Kate and talk about partnerships and the private sector and philanthropic engagement and hear about the Maverick Collective, which I'm still learning about. We had a great conversation upstairs about the next generation and how you engage people to get them interested in global health and, frankly, to finance and invest in this area. So,
Sure.
thank you.
Okay. Well, first of all, I wear two hats, and I think it's important to sort of lay out what those roles are to see how Maverick Collective really fits into the equation. So I help lead PSI, which is a global health organization, massive NGO. We've been around for 48 years, and the reason that we've been around is that we've been supported by PEPFAR and USAID and the Global Fund, many partners. And Maverick Collective came about, actually it started with a discussion that I had directly with Bill Gates and led to a partnership with the Bill and Melinda Gates Foundation, with Melinda as one of our co-founders, and the Crown Princess of Norway. And like you, we would go to sessions like this, and we would go to conferences, and we would see very similar people on the panels, and felt that we asked ourselves, where is the philanthropist in these discussions? And, you know, I've seen the work of PSI over the last, 16 years that I've been doing this. We've all made incredible strides in solving some of these problems. If you take malaria, if you take HIV, we are leading towards an HIV-free generation. We will probably end malaria in our lifetime. We're seeing the end of polio. However, where we saw a massive gap was at the innovation part, at the beginning, as the evolution with these problems that we're solving, these incredibly ambitious sustainable development goals, with the generous help of our donors, and again, PSI is very well funded by many of you who are on this panel, we were not able to really innovate. And so we saw two opportunities, and this is how Maverick Collective was formed. We felt like we were missing a ton of resources by not engaging philanthropists, certainly from the next generation, but also women philanthropists, right from the beginning, to really help us to pilot new innovation so that we could measure it, so that we could then go to our existing partners and leverage and then scale these solutions across the world. And we also have not lost sight that there is about $41 trillion being transferred to the next generation over the next 40 years. So Maverick Collective is one of the first ever communities of women philanthropists, soon some men as well, maybe we'll let you in, who share our vision that as a philanthropist, you need to use your whole net worth. And that is not just money, that is your time, that is your talent. And we believe that if we invest back into our philanthropists, our Maverick Collective members, and they become truly inspired, effective advocates, we will be able to move the needle on these issues in partnership with the Global Fund, in partnership with PEPFAR, in partnership with USAID, and with host countries. So a couple of examples here of how it works. So our members in the collective all take co-ownership of a project, which is a pilot that we implement somewhere around the world. So an example of how that has worked with this model of changing the way philanthropy and aid to a certain extent is being done. One of our members invested a few $1 million in gender-based violence eradication and invested in a project in India and Trinidad, and literally at the launch, USAID came along and said, we share this ambition to end gender-based violence. So it's now the largest, in partnership, which was your question, it's now the largest gender-based violence project in the world, in partnership with this high net worth individual philanthropist. and USAID. When you talk about South Africa, you know, the strides that we've made, as we were hearing, in HIV prevention and eradication, you know, PrEP is an incredible opportunity. It's a Maverick Collective impact project where we will align a philanthropist to invest in the very early stages of implementing PrEP, which is a prevention medication that you take when you are not HIV infected. But we want to then take that evidence and scale it across the world with our partners. And at a very early stage of really trying to discover and measure the effect of PrEP, the power of the private dollar and the power of a private philanthropist and advocate is key, because we're not getting our traditional donors to come in at the early stage. So that's what Maverick Collective is.
Thank you. So I have, Chris, I'm going to come to you in a little bit, but I wanted to follow up with our USG representatives, because this will feed into my question for Chris a little bit. I know this is a sensitive question to ask, so I'll ask it very generally, but we know that the resources that the USG has put forth for PEPFAR and PMI are significant. I mean, the most in the world, but more is always needed. So if more were to be given to you next year, what would you say would be the biggest? Where would you put that? What's the next thing, the thing to get us keep the tipping point in the right direction, both from PEPFAR and PMI's perspective?
Mm-hmm.
Yeah, so I mean, I feel very obligated to make sure that every dollar we're having right now is utilized as effectively as possible. So over the last 2.5 years, we've mapped every PEPFAR site, we've mapped every person we're reaching, we're getting incidence data, prevalence data, we've launched a lot of innovations with the private sector in the core areas of shared interests and where we haven't shown that we've had the progress, and really assured and duplicated everything with the Global Fund. I mean, Mark and the Secretariat has been enormously helpful with, I mean, down to the level of the site, and they're in our reviews saying, no, I already have a project there, and we pull out completely, or we say we have a project there and they pull out completely, and we really have deduplicated, because we wanted to assure everyone that every current dollar was being utilized effectively, because there is always additional need. But I think if you're going to go asking, you have to be able to demonstrate that you've overturned every rock. Now, have we done every single rock? I think we've done about 90% of it. And it's iterative, and it really is very detail-oriented. And then you're left with what kind of analysis, and this is what gets into building that business case. Where would those additional dollars go? We believe that it should be focused on preventing infections in the under 25 group. We're doing a lot of circumcisions for men under 25, and we're working on the DREAMS program. But remember, the DREAMS program is in very specific districts. So out of all of Malawi, it's in 3. And it's in 3 because we really want to see what's working before we take it to scale. But we also don't have the resources right now to take it to scale. But we want to create that package, because this really gets to the very absolute bottom of the issues that young women are facing. From when we talk about a young woman in a village, and we're talking about giving her, preventing child marriage, and yet she's raped at 13. So you can't get this in one-offs, okay, we're going to deal with child marriage. You have to deal with the entire child, from access to reproductive health and rights commodities, access to healthcare, access to schooling, access to a community that supports them. So it's comprehensive, and therefore it's fairly intensive, both fiscally and evaluation-wise and intellectually. And I think that's why we're so excited to have the partnership of DREAMS, because we do have Johnson & Johnson and ViiV Healthcare and Gilead providing PrEP across the board in a whole series of countries. 5 countries are implementing PrEP right now for young women, combined with the Bill and Melinda Gates Foundation helping us with evaluation so that it's independent, and no question. We have our own evaluation ongoing, but we always appreciate when they're independent. And Girl Effect, which comes out of the Nike Foundation. But I want to come back with something that Kate said. It is extraordinarily important that you don't look at public-private partnerships as a financer, because we don't. That is part of the value, particularly if it's a jumpstart issue. But that's not what really creates something that's going to innovate and really change our thinking. And that's why our partnerships are very deliberative now. We have only 4 big partnerships. One of them is Dreams. One of them is really looking at stigma and discrimination in a very comprehensive way. One of them is a new one we launched with AstraZeneca, because again, we want wellness to be important, and we want men to access healthcare in a positive way. And saying to them as the very first thing, we're worried you have HIV, shouldn't you have HIV testing? It kind of turns them off. So we're instead saying, we want you to thrive. Let's check your blood pressure, let's check for diabetes, and by the way, let's check for HIV, assess your risk. Do you need to be on PrEP? Do you need to come, what is your frequency of visits? Really changing that dynamic. But we've been very deliberative about our public-private partnerships, because we want them to be not only extraordinarily successful, but we want to use them as a learning environment to make us extraordinarily successful.
Thanks.
Couple comments. I have been asked that question a number of times. Could you and would you be able to use additional funds? The answer is absolutely yes. However, it's important that we don't play a shell game, okay?
You just got some new funds, right?
Yes, thank you very
Yes.
much to the President.
Yes.
We're very grateful.
We're all
But
excited.
it's important that as we ask the question, we're not shifting and playing a shell game from the multilateral fund. We should not take money from the global fund to benefit a bilateral program anywhere. We ought to look for an increase in the total funding to benefit the entire global health agenda. If we get additional funding, which we would be grateful for, we have demonstrated through our bilateral program that we can scale up in more countries, target more people at risk, as well as any other organization or country. And we do that through our partners. I mentioned the President. We have benefited from his very bold vision of this notion of ending malaria. Actually, it's a shared vision by many now. And with that, he committed to working with Congress. And with the increase of $200 million, let me give you an example. That would allow us to scale up in 4 new countries, cover 70 million more people. It would allow us to fill some gaps, 14 million nets. That would cover 27 million people as a preventative mechanism. We could assist countries that are on their way to elimination in a pre-elimination status to accelerate that and move even quicker and reward their good work, and significantly invest on the research side. So any increase, if we're fortunate enough to get that, we have demonstrated capacity to put it to work, measure it, and show impact. Showing impact on programs is really going to beg the question next time around.
Yeah.
Let me just comment on public-private partnerships. This is important. There's a lot of talk about that, folks, and it's really hard. I can count on one hand how many effective, measurable public-private partners, not to be confused with product development partnerships, okay? But most private companies and businesses want answers to a couple questions. What's the plan? How do we engage? Or where do we engage? How do we measure that engagement and tell it to the board or the stockholders? And then what's the exit plan? So in the initial discussion with our private sector partners, be they in the country or global, if we can begin the dialogue with, hey, here's an opportunity and here's some points of measurement, it becomes a more adult conversation rather than just a random free-for-all sitting around the water cooler. I hope that's helpful.
Can I just
Yeah.
Yeah.
Sorry, go ahead.
Oh,
Go.
thank you, thank you.
Go. Yes.
Thanks.
Yes.
Thanks.
Don't worry, Chris.
I'm working for the assumption that there will be increase in resources. Necessarily so, there has to be. If you asked South Africa, where's the plan? we'll tell you we have the National Development Plan. So it's a long-term vision. Where's the plan in relation to the problem that we're talking about? There's an investment case on the table. But what that investment case has actually showed us is the gap in information and data. We know some things. There are things that we still don't know. Specifically, the pathways that link the evolution of the disease with the structural challenges that the country faces. For any development partner to be able to assist us deal with those fundamental drivers, we need to define those pathways. If you did have additional resources, some of it should actually go to defining in more granular detail those kinds of pathways. And I think that is important, which is what DREAMS and the geospatial data has begun to do for South Africa, in fact. I think a point that was raised by Chris in his introductory remarks around the universal coverage and the opportunity of the SDGs now. How does this kind of work relate to those initiatives? Where do you fit it to maximize synergies? Can development partners identify in a specific kind of way how dealing with HIV, TB, and malaria will build resilient health systems? How dealing with these diseases will actually address the problem that we expect or are expected as we deal with environmental issues and so on. I think that the language should begin to speak in that kind of way as we talk also about antimicrobial resistance. If you have about 66 million people on treatment, that's a recipe for a thing like that to happen. So have you got built into that a program that will deal with antimicrobial resistance? So move with where the world is going and find your niche, but in a way that defines those pathways.
Great. Can I bring Chris in now, and then we'll catch up? Because Chris, you've heard this. You set the stage for us. What is this? Where do you take some of this? How do you then, move with the world and make these cases? And what are you going to do? Tell us.
I think one thing I would do is take these folks on the road. I mean, I think what you've heard from people up here in their presentations is people who are innovating, who are asking questions about effectiveness, who are expecting results. So you don't have people here who are just saying, well, we've always done it this way, so that's the way we've got to do it, only we've just got to make it bigger. That's the opposite of what you're hearing. You're hearing innovation and testing things to see what works. And I think, just this idea of talking about the success of PMI in a certain number of places, the success of DREAMS, and the fact that those are paying off and working and are innovative and are looking holistically at the problem, but aren't being scaled up all the places they could be. That's a way to start telling this story, that we have very successful things that are at the cutting edge. More people could benefit from them if we had the investment available. So I think we always look at how do you grow the global health investment, and it's tough, but I also think we've got a lot of potential here. If you look at the Kaiser poll that came out, I think in January of this year that Jen made reference to, more than 4 out of 10 people who responded to that poll said they want global health to be more a part of the next administration's agenda than the current one. So a lot of people in this country are looking for increased emphasis on global health. And the poll also found something I think is a real opportunity for us, which is that the people who responded to the poll were less likely to say they'd heard about U.S. global health efforts in the last year than when Kaiser has taken that poll in the past. So there's a deficit now, there's a waning of getting the message out about global health. Let's bring that back and get it back to what it was. Emphasizing things like DREAMS and PMI, things that are paying off right now, but also other themes that I think resonate with people. The tremendous track record results of the Global Fund along with the bilateral programs, the fact that these programs are so beneficial to women and girls and to children, all areas where the American public says they think it makes sense to be investing. The payoffs to the U.S. itself, just in terms of the public opinion in other countries of the United States being higher where we invest through PEPFAR and other programs. Global health is a security issue. I mean, there's an issue that resonates with virtually everybody in our country, and global health is connected to security. I think there's more to do there in terms of talking about that. And then I do think on the domestic side, we're already seeing, increased domestic investment in the implementing countries. I think we have to talk about that. I think we have to celebrate things like the African scorecard for domestic investment, which is out recently as an effort by African governments to hold themselves to account for steadily increased investment. That's something that Americans want to hear. I also think it's fair to say we have room to grow for all that we're doing in global health. The U.S. global health budget and the U.S. global investment in the 3 diseases has been relatively flat for several years. So I think at this time of change, new administration in Congress, it's time to ask that again. Do we just want to keep being flat, or with all these investment opportunities, is there room to grow? There are a whole host of innovative financing approaches at the implementing country level, but also at the global donor level that we're talking about, but we haven't implemented yet. So there's a real opportunity to seize on some of those and move forward with them. And we can never forget the power of how widely shared this mission is in our country. It's amazing, at a time when we're split in so many ways. The global health response in the United States has taken Congress, and it's taken the administration, and it's taken Republicans, and it's taken Democrats. All of those elements. And we've got to keep on that. And we have to remember, as we're pressing this case, to involve all those groups and bring all those voices in. It's people like Senator Lindsey Graham, who says that foreign assistance is not what's putting us into debt. Foreign assistance is making us richer, and it's about the biggest bang for the buck in the U.S. government. It's voices like that that we need to work with and hear more from. Also, I think we need to be clear now that the investment in ending these 3 epidemics and growing global health that's efficient, that is a strategic choice that we make. And I'll quote Ambassador Eric Goosby here, who is saying that the success of the universal health coverage movement and efforts against non-communicable diseases are dependent on us really driving down incidence and mortality in the 3 infectious disease epidemics. So the Indian agenda on malaria, TB, and HIV is a strategic choice to advance the other places, the broader efforts we want to do in global health. Part of the reason for that is because if you're going to go this last several miles that we have in front of us on the epidemics, it is going to mean continued investment in healthcare infrastructure in so many different ways. And it already has meant that, but certainly for the future, we are looking at continued major investments in healthcare infrastructure as we address these 3 diseases, which is a foundation for universal health coverage. The last thing I would say is we have to remember how powerful it is to be bold and say what you need. The history of the response to AIDS is of people saying to AIDS activists, well, what you're calling for in terms of investment just isn't reasonable, and then it's accomplished. That funding level is accomplished because people have been insistent, and they've mobilized people, and they've called out what's needed, and they've made it personal. So I think where we are right now is not about having to look reasonable all the time. I think we have to have data and results, and we need to show that we're being smart and we're being innovative. But really what we want to do now is change the conversation and change the expectation and say that we need to bring financing up to where we make these diseases history, and we can do it.
Great. I'm going to say we're going to go to questions because I'm losing my voice. Unless you had something you wanted.
Yeah. Chris, I think you make a fantastic point, and I want to get back to your point about being bold. I think it's a mistake to sort of lump public-private partnerships in with philanthropists into that one bucket. I really do, because we cannot underestimate the power of unrestricted funding that would allow us to disrupt, make mistakes, fail fast, redirect, so that we can get some of the measurement that we need for everyone to help us to scale. You know, there's trillions of dollars available now to solve these problems. But, you know, let me give you an example of what I'm talking about. You know, about 6 or 7 years ago, we went to our traditional donors and said, you know, we believe that by circumcising adult African men, we will have a new prevention tool that will you know, be effective in eradicating HIV. And we couldn't get our traditional donors to fund us for it. And so we took about $400,000 worth of private money that we had raised, unrestricted money, and we set up a clinic in Zambia and started to try to get adult men to go into the clinic to get circumcised. And of course we failed, right? It was really hard, like getting adult men to go into a clinic to get circumcised. So we tried a lot of different techniques to be able to prove this model. Eventually we got there, and Bill Gates came along and said, well, this is great. Here's $50 million worth of my private money. Scale it in 6 African countries. And you know, now it's one of the leading prevention tools that we have in HIV. We would not have been able to do that without private money. And you know, we have a lot of public-private partnerships, and it's restricted money. You know, it's restricted money. So I really just wanted to make that point. It's we're at a time now where, you know, certainly with investing in girls and women around these 3 issues, we're at a tipping point of being able to solve these problems. But you cannot underestimate the power of the private dollar and the private brain.
Wow. Brain
power behind it. Because, you know, there's a reason that these entrepreneurs in Silicon Valley are so successful. They're great business people.
Okay, I think there are mics. So up here, and then.
Hi, I'm Raylan Campbell, and I'm a consultant working in advocacy for global health investments, and wanted to ask about leadership change, and specifically the impact of leadership change on our ability to continue to grow the pie for global health, and within that pie, how to preserve and grow the budgets for the Global Fund diseases amidst emerging infectious disease burdens, NCD burdens, and others, and not just the US political transition, but also looking at the other big election coming up, the WHO Director General, the transition at the UN. You've got Germany, France, and a lot of the G7 governments who have been very supportive of these investments over the last decade and helped contribute to the success. But how do we engage now? How are you shaping the thinking of these emerging or upcoming leadership changes and the policies that may emerge?
Thanks. I should just say we're going to take 3 questions at a time, and she modeled perfect behavior, said who she was, and asked a question. So do that.
David Bryden with Results. To turn to the issue of TB in particular, you know, next week on Thursday we expect a really major report to come out from the World Health Organization on that issue. I think it's going to show that TB is a much bigger problem than we realize. But when it comes to TB, there are some really important innovations, to come back to the theme that you've been stressing, that are now becoming available. A point-of-care diagnostic we expect to become available next year, the Omni test, a much more sensitive cartridge for that device, pediatric formulations, a much shorter and cheaper MDR-TB treatment. But what we're lacking, I think, when it comes to TB is exactly what Admiral Ziemer was mentioning, that in-country presence, those resident advisors of the kind that you have access to through PMI. What are we going to do about that missing gap? How are we going to make sure that these really game-changing technologies on this major infectious disease are actually rolled out and become available to save lives?
Last question in this round.
Hi, good afternoon. I'm Anna Filipovska. I'm coming from Macedonia. I'm representing country coordinating mechanism from Macedonia, but I'm recently appointed representing Eastern Europe and Central Asia in the Global Fund Board. Actually, I want first at the beginning to congratulate for the successful Global Fund replenishment, like reaching almost the target for 12.9, and especially congratulations to U.S. government and the leadership there for raising $4.9 billion. Like, I would have several questions to raise, as you already mentioned, like thank you for all the contribution and share data. My questions will be regarding middle-income countries and investments that are there. And I'm sure in this room we all know the critical data which is there. And unfortunately, because I will speak more about Eastern Europe and Central Asia region, and we know that unfortunately the HIV new infections are rising in this region, 40%, where globally we have 35% decrease. And what we see actually, and there is a really interesting report I read from Kaiser Foundation. Just last year, there is 1 billion investments lower on HIV comparing with from 2014. Like, how we are going to end the epidemics and also like accomplish the SDGC if we have lower investments in middle-income countries. And also, I would like to raise the concerns with painful transitions that are there in Southeast Europe, because I'm coming from a transition country, Macedonia. Actually, as I'm speaking today, we are having protests in front of the government. We have activists there protesting because Macedonian government, they cut 56% of HIV budget, just announced 1 week ago. And we saw this kind of decrease of funds on HIV and TB in other countries in Southeast Europe. Yes, thank you.
Thank you. So we have 3 questions. I will try to summarize them. One was just on leadership transitions writ large in the world, in the US, and how do you speak to a really changing environment that's, I would say, dynamic. Second was around TB innovations, and one of the challenges in TB is, unlike, at least from the bilateral perspective and Global Fund perspective, where there's presence on the ground from PEPFAR and PMI, that TB arm doesn't have that same level of a presence, which presents a real challenge. And the third is for middle-income countries in particular that are undergoing transitions in some sense economically, so funds may be pulled out, but still have epidemics that are on the rise in some cases. How do you manage that? So tough questions. I'm going to look and see if anyone wants to take any of those on. And if not, I'll assign them to people. So, yeah.
As a largely recipient country, I can say that we have not really experienced any challenges with leadership changes in terms of commitments to global health financing, especially as it relates to PEPFAR. And I'm not sure about the experience in the Global Fund environment, but we're finding that across the aisle, the commitments to put money into solving problems that relates to global health has been the same. I'm talking from the perspective of a recipient country. But also in terms of what we do in responding to our own health challenges in the country. We haven't seen any really leadership changes in terms of how we respond to HIV and AIDS, because politicians will respond to what their constituencies are demanding on the ground, regardless of what ideology perspective they come from. And so the policies will be informed in that manner. And I think that the question of advocacy, as it speaks to the newer or emerging epidemics in Eastern Europe and so on, what helped to some degree in South Africa, it was advocacy by civil society for the policies and commitments, political commitments, especially in terms of budgets and financial commitments in solving those problems, pushed our government in a particular kind of direction, to the extent where we can say now we fund about 80% of our country response to HIV, TB, and to some degree malaria. So these kinds of issues seem to be uniform across political perspectives. That is the experience from our side.
I think those 3 questions really point out that if you don't have both political leadership, if you don't have the scientific evidence and you don't have advocacy, if you're even missing one of those, it's much more difficult. And I want to come back to Central Asia and Eastern Europe as an example. So we've actually increased our funding to Eastern Europe and Central Asia. But I will tell you, what's holding back programs is policy implementation, adaptation and policy implementation. So if the government says we don't believe medical assisted therapy is going to work, just treat the HIV positives, but continue to increase the drug using group and the access to HIV and that constant infection rate, that's like trying to end an epidemic with one hand behind your back, and you can't really do it. And I think we have to be very clear as a global community, because I think that's, and coming to the TB question, ambassadors, particularly the US ambassadors in other countries, and all these countries have US ambassadors, they have been extraordinary. Over the last 2.5 years, we went from a WHO policy guideline being implemented to directly being implemented, to being put out there and then implemented in less than a year. What did that take? That took ambassadorial leadership in country who takes the evidence to the Prime Minister, to the Minister of Health, to the Minister of Finance, at a level fed, of course, by the US government team on the ground, but constantly saying, if we do this, we can have that. And so this public health approach of ensuring everyone has access is possible because what our US ambassadors did. But I think as a global community, we have to speak out when there are issues that are keeping us from having successful global health programs, whether it's the human rights violation of some in a whole series of countries, whether it be Tanzania or Nigeria or Cameroon, where we say public health is good for everybody but them. That is not going to be a successful program. When we say that the public health interventions that we know are effective, like medical assisted therapy, cannot be utilized, we're not going to have an effective program. And I think that's when the global health community needs to say, if we can't move together, we can't move. And I think we've been reluctant as a community to say that, but I think we have to be willing to stand up for the issues that we know are critical, whether it's HIV or whether it's TB or whether it's malaria or whether it's the non-communicable diseases. You don't get to universal health care coverage if it's not for everyone in the universe. And so we think of brick and mortar often, but it's people that need to be served. And so I think we have to be much more clear and call out within the public health community when we see a country that's not allowing those critical public health interventions to be implemented. Because it's just money that's never going to have the impact that we need. And that's what we have found so extraordinary about PEPFAR in the last couple of years, is the partnership between the host country, the advocates, and the US ambassadors in countries who have really worked tirelessly. I mean, Ambassador Gaspard and the Minister of Health are very close friends and move together. Aaron Mosoletti and Ambassador Gaspard are just partners because we know how we can be effective when the ministry is leading and we're supporting, and it's really been extraordinary. That has to happen in every country.
2 quick comments.
Yep.
As I mentioned earlier, leadership changes happen. It's part of life. But as you look at the success of the programs and the work that's been accomplished, a lot of attribution could go directly to the HIV advocacy community. And we need to acknowledge that. And then as we look forward, also celebrate other very effective advocates, like Nothing But Nets and Malaria No More. Who better to advocate for the cause of global malaria than Steph Curry? For every 3-pointer that he makes, he buys 3 bed nets. Okay, that's phenomenal. That is advocacy at its best, and the malaria community has benefited from that. One citizen who's pretty famous advocating for malaria that doesn't exist in this country. Okay? So I think this is a charge for the advocacy community to pay attention and to continue to do what you're doing so well. Because as the leaders come and go, the response from the civil society and the community and the citizens really help influence priorities and leadership imperatives. I won't comment on TB. I defer to Ambassador Birx on that. On the middle income question, that is a good question, but I think from my perspective, we look at it in terms of resources available and where the disease burden is the greatest. And for malaria, that's clearly sub-Saharan Africa. And right now, while we celebrate more money going into malaria than ever before, we still have a $2.4 billion gap per year. And if you look at the cost of eliminating malaria through 2030-35, it comes with a healthy price tag of $110 billion. So as we continue to mobilize funds and focus on where the disease burden is the greatest, it's usually the poorest, most remote folks that we love and serve, okay? So I am encouraged by the progress made in Latin America and the Asia Pacific. They're mobilizing without significant offshore resources. They have a strategy. They're looking at their own constituency to move towards this global goal of malaria elimination. So I think we just have to understand the picture, look at the resources, and then focus on where the need is the greatest, and then continue to work hard. I hope that's helpful.
Chris, thank you.
Yes, I mean, I would also just say that on the issue of global health financing in the future, we need to be thinking more about financing advocacy. It is been called by the Lancet Commission on Ending AIDS a global public good, and that should be funded commensurate with the huge contribution it makes in the AIDS response. And you know, we are underfinancing advocacy right now, and it's tough too, because financing for advocacy often isn't done, and in some ways isn't even appropriate to be done by the government in which you're doing that advocacy. By its nature, advocacy financing often has to come from the private sector, from philanthropy, and from donors outside of that government, so that the advocate can be not compromised in any way and can push and hold accountable his or her government. I really want to applaud Ambassador Birx, who's always understood the power and importance of advocacy, but also has stepped forward and increased the U.S. commitment to the Robert Carr Network, Civil Society Networks Fund just last year, that's an extremely important fund. We need more things like that. The government of the Netherlands, for example, is really invested in supporting advocacy in countries around the world. So it's doable, and we have great examples, and I think we need more of it. And I think we really need more advocacy, certainly in middle-income countries, just as you're saying. And I think we do need advocates financed to be working with their governments, but also with the Global Fund and other major players to observe how these transitions in donor aid are going and make them as smooth and effective as possible. Now, the Global Fund does have policy pieces in place to try to smooth those transitions, including readiness assessments and incentives and requirements that governments, as they bring in more of their own money, are putting more of that into key populations, into evidence-based policy, and that investments are implemented through country systems so that as there's pullback, that there are strong systems. But we don't know that that all works perfectly, and I think we absolutely need the advocates working with the big partners and the domestic governments to make it as good as possible.
Do you want to add anything, or should we go for more questions?
I could add into that.
Quickly,
on the advocacy piece, I think, Jennifer, yes, central and important, and Chris is referring to effective advocacy in relation to funding advocacy, but we need advocates who have clear understanding of the biomedical knowledge on the issues, who also have skills for advocacy, so that they can negotiate on an equal kind of basis with people who have power to make these kinds of decisions, be it governments, be it corporates. So you need to empower your advocates with funding, with knowledge, and the skills to do the work that needs to be done in advocacy, yes.
I just want to add a very small thing. And we haven't really touched upon it in this panel, but filling a critical gap in between what the governments are doing and what civil society is doing is that middle ground, right? Building markets to work for the poor, looking at sustainability, some of these sustainable programs that can work. There's trillions of dollars at the bottom of the economic pyramid. We need to start testing out these social enterprise models and making sure that clinics on the ground, private sector clinics, have the capacity. You talk about TB, experimenting in different ways of how we start prevention and treatment. So I can't underestimate the power of also the private sector and working the NGOs out of business, like working PEPFAR out of business, working the Global Fund out of business. We need to start investing in that. Dibs,
Let's take 3 more questions. One up here, there's one back there, and I think I see another hand over there. So wherever the mics are closest, 1, 2, 3.
Hi, thanks to the panel members. My name is Priya Sharma. I work at USAID, and this is a question for Chris. I was just wondering, you mentioned innovative financing mechanisms that are sort of filtering around globally and at the country and regional level. I was wondering if you had any particular examples in mind and then thoughts for how donors like USAID and others can get involved in helping to scale some of those.
Okay, where's...
Hi, Dennis Nazaroff, Associate Director of Global Policy at AIDS Healthcare Foundation. I have a question perhaps for Chris. So we at AHF applaud the U.S. for leading on global fund replenishment, and we're very happy that the Global Fund nearly hit its goal. But in all of this, there's one major donor who's conspicuously missing in action, and that's China. China is an economy with $13 trillion. The one after that is Japan. So Japan's only $4 trillion, and Japan has contributed $800 million to the Global Fund replenishment, whereas China has only upped its contribution by $3 million from 15 to 18. So clearly, if we talk about mobilizing more resources, I think there are other major donors who are still holding out. So my question is, what can we do on the political arena and also from the civil society perspective to inspire or perhaps pressure China to do more? Thank you.
And our last question for this round.
I'm Robert Clay with Save the Children, and first, thank you very much for a great panel discussion. I think a strong message has come out, which I firmly believe that we need data and evidence to be able to justify our programs. But we know as we go through the next 15 years, we're going to be focusing on a lot of fragile countries with weak ministries. We're going to marginalize populations. And so getting that data and having that evidence is going to get harder and harder. So I wondered if you could just comment a little bit on that. Save the Children, we're principal recipient for the Global Fund, and half of our countries are in the fragile state, and it's becoming more difficult to be able to get that evidence. So any comments would be welcome. Thank you.
Great. So we had a question about innovative financing models and ideas for potentially USAID. This issue of mobilizing other donors that may not, it's really a fair share question, and how do you even evaluate that? And this third question on going forward, the work might be harder or will be harder in a lot of ways. How do we measure it? Who wants to? Chris, you were asked.
So on innovative financing, I'm not the world's expert on it, but I think there's a few things that people are talking about that I know about, and then I'm sure there's others. For example, one that is not for USAID to do, but the idea of a financial transaction tax is something that many very prominent people in the world have said is a really good idea. It's something that Europe has actually committed to. I think it's now on delay, but at one point was committed to moving forward on a financial transaction tax. It is actually part of the Democratic Party platform right now, although the idea would be that it would be directed more towards domestic priorities as far as I can understand, and being on that platform doesn't mean it happens. But the conversation's happening, and a lot of highly credible people have said there's a lot of worth in looking at an FTT. So the idea of social equity financing is another thing that's being put out there. There are some precedents for it. There are some investment firms that have models of that. Could we scale that? Is that an opportunity looking forward? is that an opportunity for USAID? I don't know. It might be. I think that we need to move forward in the conversation on innovative finance, and we also need to be very careful as we move forward on that we keep the bipartisan coalition in support for a financing method. So that's the one thing I would say in terms of USG implementation of any of this, that we want to make sure we're bringing everybody along and seeing why that's the right way to finance it. But there's other ideas, things out there that are happening right now. Unitaid, an incredibly impactful organization, is financed largely through an airline tax that France pioneered and then other governments have adopted themselves. Norway, at least at one point, and I think still now, has a carbon tax, part of which goes to global health. So there's a whole lot of ways we can do this. There's a whole lot of ideas to build upon. I just think we need to dive in and with all the consensus we see on the importance of global health, start realizing we need to start taking advantage of these and start moving forward on some of them. Now, on the question of China and advancing the Global Fund, you'll be shocked to hear I don't have the answer. Although I would say a couple things. One is, as tough as it might be, I think that investment in civil society is crucial in every country, including the United States, in terms of domestic investment in the Global Fund. And I will say that, having been at replenishment, it was my first replenishment, you just had a feeling being in the room there that the ministers of health and prime ministers who were there, it was a club that people wanted to be part of. I mean, the Global Fund is one of those places that is a global meeting point that you want to be associated with. And I think that's very, very good. And I think, I don't know how we get China there. I'm not the expert on that. So I really would defer to the Secretariat on that. But I think you're right. We need to, I think advocates like yourself need to be asking that question and supporting advocates in country on that.
Just quickly on China, and then I'll go to the question on the fragile states. That we have to recognize that over the last decade, China went from not treating people till they were very sick and not addressing their HIV/AIDS problem to a very comprehensive response to their HIV/AIDS problem that didn't exist 10 years ago. And so I hope that with that evolution, we will see this evolution to investment on the Global Fund, because they've really made incredible strides forward to compare to where they were just 10 years ago. And I think, Robert, your question about fragile states, what's really has struck me as we see how the epidemic is evolving everywhere, and it doesn't matter if it's HIV or TB in particular, we have fragile states, but we have fragile communities, and we have fragile people. And part of what we need to always be doing is to ensure that we have the denominator that brings visibility to the invisible. And I think that's part of our role every day. And whether that's 14-year-olds who are raped, or 14-year-olds who are no longer in school, or the LGBT community who is marginalized, or the sex worker that are marginalized, to the absolute fragile states, is to really work to define the issue and address the issue and not just talk about the issue. And I think that's the piece where I think we can all come together and really agree so that we can show progress there. Even in the most fragile of environments, right now in South Sudan, our partners are reaching people who are in need of HIV services. And it's so humbling to see what partners on the ground are doing in the most difficult of circumstances. So we have seen over and over again, when people are given the resources and the ability, they reach the needs of the individuals they're serving. And so I'm very hopeful about all of that. But I think the SDGs, in order to be accomplished, whether it's fragile states or fragile communities, we just really need to know, we really are learning now that 80% of the issues are in 20% of the geography. Mm-hmm. And now we have to focus resources in that way. And I think once we do, we will see a dramatic impact on not only teen pregnancy and child marriage and gender-based violence and NCD reduction, but we really will see transition from fragile communities to healthy communities.
So I think we have time for maybe 1, 2 at the most questions. Yeah, back there, we have one.
Thank you very much. My name is Marielle Hart. I'm a policy manager here in Washington, D.C. with the International HIV/AIDS Alliance. And I have a question for Dr. Nolutshungu from South Africa, particularly in relation to universal health coverage. I was just curious. I mean, universal health coverage has been on the global political agenda now for some time in relation to the SDG discussions. I'm very interested to see how countries are going to move forward on this agenda. And so I was curious if you could share some thoughts about how South Africa is working towards universal health coverage, and in particular how the HIV response fits into that, or how it's all related together. Thanks.
One quick, very quick.
Hi, I'm Selena Shocken from Pink Ribbon, Red Ribbon. And I was wondering if you could talk a bit about other co-infections in addition to TB, and also what we're going to do with funding for other NCDs and other emerging diseases coming forward.
Okay, in our 5 minutes remaining, we can tackle both of those things.
Yes. In terms of universal health coverage, thank you for raising that question. That's an important policy issue for us. It's supported at highest level of the executive and in parliament and by most of the political parties in the country. We're in discussion with the private health sector to see how best to have them engaged in the process of developing the National Health Insurance Program. We gave ourselves about 15 years, and we've done about 5 years of that now, building the blocks, especially at district level, to make sure that the package that is being defined for primary health care, which is planned to be equally available across the board, is defined and agreed upon by all. We're looking at the best financing mechanism for that, and the discussions, as I say, are underway with the private health sector. HIV will always be a big element of universal health coverage. In fact, it is our experience that when we dealt with HIV, it contributed to the building of the health system in the country, laboratory health systems, information systems, health infrastructure, human resources and training and all of that. So we're leveraging the HIV response to improve on the health system as we improved also issues relating to quality. We do have a white paper that is out now. It's being negotiated by all parties, and the next step would be to take that to Parliament in terms of formulating all the regulations and basically district health system and primary health care is going to be the bedrock of universal health coverage, and HIV will be a big element of that. The other question was on
Pink Ribbon, Red Ribbon. So I think it's a great place where we started about bipartisanship, and this takes us full circle again. So thank you for bringing that up. We all know President Bush was instrumental with the U.S. Congress in launching PEPFAR, and then realized that young women that we were saving and that lives were saved because of being on treatment were ending up dying from cervical cancer. And so the Bush Institute went to Secretary Clinton with the issue and really dramatic facts about the aggressive nature of cervical cancer in HIV positive women, and a solution that could be pennies to change the world. And so Secretary Clinton and the Bush Institute and President Bush launched Pink Ribbon, Red Ribbon with UNAIDS, and in 5 years has gone from strategic plan for cervical cancer, primary prevention through immunization for HPV, secondary prevention through screening, to now Botswana and Zambia taking on it as a total sustainable U.S. government, host government, completely funded program that's reaching millions of women. And that's the power of some of these, what really was described as some of these high-risk pieces. When you say you're going to take on cancer, people get a little bit nervous, but having an outside group come with the U.S. government to say this is important, and then show in 5 years the host government taking this on as a solution for all of their women in the country, really, I think, shows the power of some of these partnerships that are continuously have high-level political leadership and real host government acknowledgement and investment. It's been incredibly successful.
Great. So in the interest of full circle, I think we're kind of out of time. I'm going to bookend it by letting Chris have the final word. But just an observation is if you think back to when PEPFAR, well, the Global Fund was first a discussion, not even yet created, and then just a couple years later, the PEPFAR, that was almost leap of faith of government saying, okay, we'll do this. We'll launch these huge scale programs. We don't have the data. We don't know if they're going to work, but we're going to do it. And now here we are. We have a lot of data, and we have a lot of effectiveness, and we can show that millions of lives have been saved, and we're having to make a different kind of argument. So I think that's a big challenge. But I'm going to let you have the last word, Chris, as to bookend us.
I just want to say thank you, Jen, for hosting us and for being our moderator, and to the panelists. All of you were wonderful and creative and innovative, and you're who people need to hear from. So I want to thank you. I really want to thank the whole staff of Friends of the Global Fight who spearheaded this event and thought it up and put it together and made it happen, and everybody who came. So I thought this was a detailed and optimistic and thoughtful conversation, and let's have more.
Thank you.